So I'm Dr. Katie Larson Ode. I'm actually a pediatric endocrinologist, and I am from Iowa, as it says very loudly on my slide. And I see both adults and pediatric patients who have cystic fibrosis. And my area of expertise is cystic fibrosis related diabetes. And my favorite thing in the whole world is trying to figure out why people with CF get diabetes. So that kind of informs my my approach to this topic that we're going to talk about today. So the big thing is I am a diabetologist. I'm not a GI doctor. So this is going to come from an endocrine person's point of view, but I am going to talk about both parts of the pancreas. So so my disclosures, this is a picture of Iowa. So I have research funding from the Cystic Fibrosis Foundation from the NIH. Relevant to this talk, I did sit once and got paid for being on advisory board for Vertex exactly once. And so I'm going to talk about medications that they make. So that is a potential conflict of interest for this talk. I'm also an editor for Up to Date, which is our major online textbook for physicians for cystic fibrosis related diabetes content. And I like Iowa. So, so in other background, because just to introduce myself a little further, I trained in all over the Midwest, did my peds residency in Ohio, did my endocrine fellowship in Minnesota, which is the epicenter of cystic fibrosis related diabetes training, which is part of how I got into it. And then I did my MD is from the University of Wisconsin, so I hail from like the whole Midwest. But that's kind of my background. So cystic fibrosis related diabetes, and I think this is probably not new to anybody here, but it's always good to clarify where I'm starting from and the terms I'm going to be using just to make sure that we're all on the same page. Cystic fibrosis related diabetes is very common historically in people with cystic fibrosis. It is an extremely it is unique type of diabetes, so it's quite different from type 1 and type 2, which are the more common forms of diabetes, and that causes a lot of trouble for people with cystic fibrosis when they have to interact with the medical system, because people tend to make assumptions based on other forms of diabetes. And then in the context of the talk, I will be talking about OGTT, by which I mean oral glucose tolerance testing, which at this time is our recommended screening test for cystic fibrosis related diabetes and forms of prediabetes or abnormal glucose in people with cystic fibrosis. So let's talk about the pancreas, because that's kind of the goal today. So this picture is a picture of what the pancreas looks like if you cut it up and put it on a slide. The dark pink and dark purple part is the exocrine part of the pancreas. So that's the part that makes our digestive enzymes. That's the part I have much less expertise in, but I think it's really important. And then that little part in the middle that's light pink and lighter purple, that's the islet. And so that's where all the hormone secreting or endocrine cells live. So that's my part of the pancreas. So most of the healthy pancreas is the digestive part, and only tiny, tiny parts are the diabetes part. So that's a healthy pancreas. So this slide, other slide that's not in color, this is the picture from Dorothy Anderson's original paper when she figured out what cystic fibrosis was. And so when she discovered cystic fibrosis and described it, it's cystic fibrosis of the pancreas is the name of the disease. That's the full name of the disease. And because people died of the exocrine pancreatic disease. So little kids died of failure to thrive and dehydration. They didn't live long enough to get lung disease, actually, of any substantial degree. So this is pancreas pathology is actually an intrinsic part of the disease, but we tend to back burner it quite a bit because of the importance of lung disease once we developed enzymes to treat the function of the exocrine pancreas. But the digestive part of the pancreas is actually very, very important for life. We just found a way to treat it, and then the lung disease was much more of a challenge than the exocrine disease was as far as the early treatment. But I just like to remind people that that this is really an intrinsic part of the disease, especially when I talk to pulmonologists. So in this picture, what you see, the big round things are the islets, which are still there, and everything around them is just scar tissue. And this is from, I think, a 2-year-old with cystic fibrosis, what that picture is from. So when we're talking about the exocrine part of the pancreas or the digestive part of the pancreas, The previous natural history in people with classic CF who aren't on what is termed highly effective CFTR modulator therapy, exocrine pancreas disease starts in utero. And then 85% of people with classic cystic fibrosis are pancreatic insufficient starting in childhood. And most people who are pancreatic insufficient will be there by about 2 years of age. And currently, we consider that pancreatic insufficiency is expected to persist for life. So natural history of endocrine pancreas disease. Of course, I care more about this, so this slide's longer. The primary problem is that you can't make infinite amounts of insulin, which a normal healthy pancreas can make nearly infinite amounts of insulin. And that ability to make insulin gets worse over time. And the sad thing is that if you do really, really, really detailed testing in the old days, everybody with CF had some degree of abnormality of insulin secretion, even if they never had abnormal blood sugars. And interestingly, even though people who are pancreatic sufficient have much, much lower rates of problems with their blood sugars or cystic fibrosis related diabetes, if you do that really, really invasive testing, people with CF who are theoretically normal from a pancreatic sufficiency standpoint still have some degree of decreased insulin secretion. And of course, the worse your pancreatic exocrine or digestive disease is, and the earlier it starts, the more likely you are to have CFRD. So other things in the previous times is that the ability to tolerate glucose typically would wax and wane. So people would get worse, then they get better, and they get worse then get better with their blood sugars. And that would slowly progress or quickly progress to true diabetes and eventually insulin dependence, assuming somebody would live long enough. Fasting hyperglycemia, so high blood sugars when you haven't eaten anything, it's a late finding. That's not a late finding in type 2. So in adults, fasting blood sugar is a primary screening test for diabetes, and it's not a great test in people with cystic fibrosis. And then historically, if you had a bad OGTT test and then you had a good OGTT test, you still had increased risk of poor outcomes and diabetes complications, even though your OGTT got better. And historically, there was clinical decline, that is more increased rapidity of the decline in lung function over time, and decreased BMI would occur because of abnormal glucose before anybody ever had anything that would make you think they had diabetes, which is why we've always recommended screening. And the presence of diabetes or prediabetes would increase the likelihood of pulmonary mortality, not from diabetes complications, but from pulmonary disease. So that's the way it used to work. So one of the terrible things about the pancreas is that animal models for the pancreas that look like human pancreases are actually pretty hard to find. Mice and rats have very different pancreatic structure with a much more protected islet than what you see in humans. So, and also rats and mice with cystic fibrosis don't get spontaneous diabetes the way humans do. You have to do things to poison the pancreas in a rat or mouse CF model to get them to get diabetes. So for a long time, we didn't have any good basic science way to address either the exocrine or endocrine pancreas in CF. The development of the ferret and pig model and then other subsequent non-rat, not mouse models have really improved this. And so I have for many years worked pretty closely with the CF ferret team. And so this is some pancreas pathology, kind of like what I showed you earlier, but from the CF ferret. And the interesting thing about the CF ferret, which is very different from the human people are born with completely destroyed pancreases with classic CF. But the ferrets are born with a relatively healthy pancreas. So that pancreas on the left, all that pretty pink, that's that same pink tissue, which is the exocrine or digestive part of the pancreas that I showed you in one of my first slides. And then as the little baby ferret gets older, they have progressive loss of their pancreas tissue. And that blue, as you can see, it's going from pink to blue. Pink is good, healthy tissue. Blue is scar. So that's your fibrosis. So that stain, the blue stain picks up fibrosis and scarring. So that's your cystic fibrosis. And if we had colored stain on that of Dorothy Anderson's picture, it would look very similar to that picture all the way on the right, the day 32 ferrous. And so this fibrosis correlates also with pancreas inflammation that you see in the ferret model. So then, of course, because I'm an endocrinologist, what I actually care about is this clear disease of your exocrine pancreas related to the blood sugar problems? And of course, the answer is yes, but here's some data. So this is more baby ferret data. And this is these little blue points are the baby ferret's blood sugar before and after you feed the baby ferret. And ferrets, nicely enough, have exactly the same normal blood sugar range as people do, which is not true for mice. And so here, the red is a baby ferret with CF, and the blue is the baby ferret sibling who doesn't have CF. And so, and their blood sugars before and after feeds. And so what you can see here is that they're normal when they're born, and then they get very abnormal. And then they get closer to normal, and then they slowly progress to being more and more abnormal in their blood sugars with time. And this actually correlates really nicely with those with the damage to the digestive part of the pancreas that I just showed you. So what we know is happening in the baby ferrets. Whoops, that was bad. Okay, what did I do there? Ooh, get me back to where I was. Okay, sorry about that. Oh, now I have to switch this thing again. There we go. Sorry. And so, and so what's happening here with the pancreas is that the pancreas looks good. The pancreas gets really inflamed, but isn't that damaged. And then you actually see the kind of fibrosis happening, and then it stabilizes, and then it kind of just sits there and looks terrible. So that's what it actually matches. So actually, when we found this data in the ferrets, I went and looked at little people with CF, because at that point we thought there was nothing happening from a blood sugar perspective in little kids with CF until they were 10. We knew that the pancreas damage was happening in utero with people with CF, because actually the newborn screen for CF actually picks up in utero pancreatitis. That's the primary part of the screen, and then it reflexes to genetic testing. But actually the initial test, which is the trypsinogen, that's actually a pancreatitis marker. So you're having in utero pancreatitis is known and had been known for a long time in little children with CF, but we thought that the glucose stuff came much, much later. But it turns out that little kids with CF absolutely have blood sugar problems when they're very young. And then it kind of seems to get better and then get worse again with age, much like what we see in the ferret model. So, of course, what's been happening to me for several years now is people ask me, will our highly effective, like how do highly effective modulators change all that stuff you just showed me that we knew about how the pancreas disease works? And of course, in my case specifically, how diabetes and abnormal blood sugars work in cystic fibrosis. So, of course, if this is going to go from easiest to fix to hardest to fix in terms of options of what could be going on. So if there is CFTR in the beta cells, which are the cells that make insulin, then fixing the CFTR should improve your insulin secretion. And we know that not enough insulin is the primary problem for blood sugar problems in CF. So that would be great. If there isn't CFTR in the beta cell, then maybe there's CFTR in some of the other cells that are inside the islet that can directly support the beta cell in its job or stop antagonizing the beta cell. And then if there's nothing in the islet itself, maybe there is maybe improving CFTR function in whatever is left outside the islet may support the islet in its function. Maybe we can reduce any inflammation within the islet, and that'll improve islet function. Or maybe we have to prevent or stop any destruction to the digestive part of the pancreas in order to save the islet from getting diabetes. So those are some of the options for how modulating CFTR could potentially modulate exocrine endocrine pancreatic damage. So first question, is there CFTR in the islet? So is CFTR in the beta cell? So there was actually a lot of excitement about this. You guys probably have seen some of this if you've been following literature at all, but there is some serious background why we thought for a long time we were going to find CFTR in the beta cell or substantial amounts of it. CFTR is a chloride channel, as people probably already know, and it's really closely related to a really important potassium channel in the beta cell, which is the primary channel that actually stimulates insulin secretion, which is called weirdly the sulfonylurea receptor, because we found a medication that worked on diabetes, and then we figured out what it bound to, because science is weird. And so we knew that, so it made sense that it could have function in the beta cells. And then there were a bunch of groups that found CFTR in rat beta cells and some models of beta cells that aren't actual human beta cells, but are models of human beta cells. So we got very excited. But unfortunately, that couldn't really be replicated. And then finally, the group led by Hart, they actually did single cell RNA-seq on human pancreases from donor pancreases. And they just ran all the cells through a cell sorter and figured out what kind of cell they were and figured out what they had for protein in them and mRNA. And what they found was that only a very small percentage of cells that could be considered to be beta cells, people argue if they're actually beta cells or not, have some CFTR mRNA. So most beta cells do not have CFTR. That's a pretty safe statement. And I would say that we would pretty much agree based on our clinical experience that highly effective corrective therapy doesn't magically fix diabetes. So when I first started giving this talk, we didn't actually know that, but I would say that's probably pretty clear clinically now, even though we don't have that much science data yet. And the other thing is when we figured out it wasn't in the beta cell, we went through a lot of iterations with all the other cells in the islet, which there are actually a whole bunch of different weird endocrine cells in there besides just beta cells, but none of them have any more CFTR than the beta cell does. That's the short version of the story. I used to have about 6 slides on that, and now I'm just gone. So anyway, we do know that the exocrine pancreas has tons and tons and tons of CFTR. The exocrine pancreas is completely dependent on CFTR to function. So the question is does the exocrine pancreas, if you help even the tiny remnant of little bit of exocrine pancreas tissue that's left, does that help the islet be healthy and do its job? Well, it probably does, interestingly enough. So we actually have a decent amount of data that's been around actually since as early as 2005 that duct cells are actually really important for the function of the islet. We like to ignore it, but the data's been there for a bit. And the cells actually talk to each other. So hormones are chemical messengers that go from like one part of the body to way far away to another part of the body. But actually there's localized hormones as well, which are called paracrines. And it turns out that the exocrine and endocrine pancreas talk to each other with paracrine hormones. And so it turns out as well is whenever somebody isolates an islet, it actually always has some exocrine tissue stuck to it. You can't get all the exocrine tissue off the islet because actually exocrine tissue is really important to the islet. But endocrinologists like to pretend that it's not because we like to separate away from the GI people. Oh, get away, get away. But so islet cultures actually always have duct cells. So some of my colleagues who are some of the ferret people got some human islets. They isolated them per usual protocols. And then they knocked down the CFTR in the duct cells that they couldn't get off the isolated islets. And what they found in both human and ferret islets that didn't have CF, these are wild type humans and ferrets, that the ability of those islets to make insulin when triggered with sugar intake, was reduced. And so the left hand D is the ferret islets, the right hand E is the ferret islet, the human islets. And the red is after the CFTR had been knocked down in the duct cells that are attached to the islets. And I think it's pretty easy to see that there was a lot less insulin secretion. And of course, the point here is that the low glucose situation, which is the left side of both of those, there's no change there, which is, as we see frequently in cystic fibrosis, that it's the challenge of having to eat stuff, which of course we all have to eat, that really brings out the problems rather than when you're not eating anything. So it turns out that looks really important. The other thing is we know there's a ton of inflammation in the exocrine tissue in people with CF and especially little kids with CF. But for a long time, we really didn't think about inflammation within the islet in CF. In rats and mice, which I keep bringing this up, but their islets are really isolated from the exocrine tissue. So like they're typically the inflammation they're protected from inflammation. But in humans, as I mentioned, there's lots of crosstalk between the two tissues. So it turns out there's actually quite a bit of inflammation within the islet as well as in the exocrine tissue, even though the islets aren't dying the way the exocrine tissue is. And so we have found that inflammatory cytokines are present in the islet and likely within the beta cells in people in CF tissue. We find T cells, which are the killer cells of the immune system, inside the islets. And actually, they're the same ones that cause type 1 diabetes. We see those in CF islets. And then the CF pig islets have some other markers for inflammation as well that we have found. And I think the most interesting part of the inflammation discussion is what's going on with macrophages. So macrophages are actually, there's a lot of macrophages that live in all sorts of tissues. For example, the lungs have macrophages that live inside the alveoli that are really important for lung function. It turns out that islets also have, or are supposed to have, resident macrophages. And these macrophages are actually important if you're going to grow back any part of your islet, although humans are unbelievably horrific at growing back their islets. The little bit that we can do is dependent on the presence of macrophages. And in our ferret model, these islet macrophages are really important for the recovery from dysglycemia. And then it turns out these islet macrophages really aren't present in adult pancreases in people with CF. And so the CF and people with CF probably have macrophage dysfunction, and CFTR modulators probably restore macrophage dysfunction. Although when I've talked to a couple of CF macrophage experts, I guess this is not as well established as I thought when I made this slide. So it's very possible that inflammation is part of what is going on in the endocrine pancreas as well as the exocrine pancreas in CF. So
Can
what
I
do we have
jump
to
in? I have a question.
Yes,
Yeah,
yes.
so what are the exocrine and endocrine systems like saying to each other? You said there's some hormone crosstalk going on. Do you know what they're talking about?
Sorry, I couldn't quite hear that. There's crosstalk
Oh.
between the exocrine pancreas.
Yeah, what are they saying to each other? What's the communication going on?
Yeah, so that's a great question. I'm not 100% sure, but what I will tell you is that we think of insulin secretion in the context of the sugar in your blood goes up and you make insulin. And that mechanism is really, really well understood. However, in a completely healthy individual who doesn't have any type of diabetes or GI problem, as soon as you smell and taste insulin, we have something called the cephalic phase of insulin secretion. So you start making insulin before your blood sugar ever rises. And so you get signals both from your brain through the vagus nerve, and you get signals from your intestine, and you get signals from the digestive part of your pancreas to the beta cells and to the islet to tell the islet there's food coming, start making insulin. So this is one of the tough things. And that's actually the first thing you lose with any type of diabetes. And that's also why you get a different insulin increase if you give people oral sugar versus IV sugar. So oral sugar is better for you than IV sugar if you are healthy, because your body can prepare for oral sugar. Whereas when you give sugar IV, all you get is the hit of the blood sugar rising. But if you eat sugar and you taste it and smell it and you psychologically know it's coming, which is part of the problem with diet beverages or things with artificial sweetener, you actually have all the mechanism neurologically and from your GI tract perspective that signal to your islets to start making insulin and also to reduce the hormones that fight against insulin. So some of the signals, I don't remember, I didn't write down the names of the signals between the exocrine and endocrine pancreas, but basically what's happening is as you're stressing the exocrine pancreas and it's trying to release the digestive enzymes, it's sending signals to the endocrine pancreas to start making insulin. Did that answer the question?
Yeah, that was great. Thank you. I'm also getting hungry now, but that's good.
Yeah. So some of this is like how those new fancy diabetes medications like Ozempic work. Ozempic is a mimic of one of the hormones that comes from the small intestine to the islet, a GLP-1. So yeah, so we are just starting to think about all of the hormones that come from the GI tract that are important to cause or treat diabetes. We've really kind of only scratched the surface in some ways with some of these hormones. They actually described a lot of them back in the 70s, but then they kind of didn't go anywhere. Everybody forgot about them for a while, and they've just kind of resurfaced as being really important parts of diabetes, which has been kind of funny how you find something and then you don't know what to do with it, and then later you figure out the relevance of it. So, any other questions? That was a great question. All right, I'm going to keep talking unless somebody else has a question. So, ivacaftor for gating mutations, so the G551D and related mutations, has been around a lot longer than other highly effective corrector therapy. And so we have longer, like more time experience, but a much smaller number of people experience, if that makes sense. And so what we know for ivacaftor and diabetes risk is that with ivacaftor, you see a little bit of response in insulin levels after somebody's been on ivacaftor, a little bit of an improvement. You see a little bit of improvement in markers of beta cell function. And then we seem to be seeing less diabetes in people who can take ivacaftor over time from registry data. So both in the US and in the UK, which is pretty cool. So when I first started giving this talk, there wasn't really any data on elexacaftor, tezcaftor, ivacaftor, or trikafta, but now there's actually tons, although most of it's not very good and the studies are really small, but there's a lot. And so this is a really busy slide. I'm just going to try to walk you through it a little bit because they unfortunately studied a bunch of different things in a bunch of different people. So this is all the ones that go together when they're looking at the same thing. And basically the short version of it is those are OGTT tests. This is CGM data. And then here's A1C. And other than A1C, everything goes both directions, basically, in this data. That's the short version of the story. And then there's been some more studies that have been published since that. These ones all found positive results. Although, of course, the problem with small studies in an area like this is that things that find good things are more likely to get published. So there's always a little bit of a publication bias towards positive findings. The one good thing in the newer data is there's one study that has more than 40 people in it, and that's this last one, but it is they just pulled data from a large existing data set, but they found A1C improved after people had been on ETI. So there's one good study where they looked at what would be happening kind of in the background in people when they start ATI, but it's a really small study. They had 9 people who had MMTT, which is a meal version instead of just straight sugar of doing an oral glucose tolerance test. And then they did this thing called a glucose potentiated arginine test, which is a super fancy investigational research test that is really, really good at finding small variations in the ability to secrete insulin. And what they found is that ETI did improve insulin secretion a very tiny amount. And what they decided is probably what this means is that people who on ETI are probably not going to get worse over time, like people were expected to do before ETI. And I would say that I think that's a general takeaway from the data we have is probably a little less progression over time. So let's talk about the other part of the pancreas that I'm not as much of an expert in. So there is very little ETI data. There is quite a bit more and pretty good ivacaftor gating mutation data for the exocrine pancreas, interestingly enough. So here's a nice systematic review of ivacaftor and exocrine pancreas function. So they pulled a bunch of studies. And of course, people with G551D and other gating mutations typically have less damage to their CFTR function at baseline compared to people who are delta F508, delta F508. So it's a little bit less severe CF on average, I guess. But they had almost a quarter of, these are completely pediatric patients in these studies who converted from being pancreatic insufficient to being pancreatic sufficient. The strongest effect they found in all these studies was that the younger you are when you start highly effective corrector therapy, the more likely you are to improve your exocrine function. And so people look at it both conversion from pancreatic insufficiency to pancreatic sufficiency, And then also the actual marker that we use to diagnose pancreatic insufficiency clinically, which is fecal elastase, being either less than or greater than 200. And so they had the first study, they had about a fifth of the people going from PI to PS, and then a couple case series that checked this fecal elastase. In some studies, they found almost half of the people improved their fecal elastase clinically significantly. And then in the people who became pancreatic sufficient, they were more likely to be younger, and they were more likely to have had some fecal elastase that they could find at baseline, which makes sense. And this is a bunch of different studies. They're showing the change in fecal elastase, and you can see that I varied a ton from study to study, of course, because we can't have that.
Does that include people who went down on the number of enzymes that they take?
Oh, so you can't do, you don't do fecal elastase testing on somebody who's taking enzymes at the time? Because that's a great question, because the test will pick up the enzymes. So you have to hold enzymes to do the test. That make sense?
Okay, so they didn't research people who went down on enzymes because of that?
So well, they didn't in these studies because these were little kids, but there is some data in older adults from ETI, which I have in like a slide or two, looking at people who were able to go down on enzymes, because that's kind of a slightly separate question.
Yeah.
So this is people who went from clinically needing enzymes to clinically meeting all criteria to not need enzymes. So there, those studies I just showed you is either like 100% you need enzymes, 100% you don't, and not anybody who's kind of in between. But when I get to the Trikafta data, there is a little bit on that, but there isn't any to ivacaftor data. But great question. So the best studies on ivacaftor are the Arrival. These are all in really little kids. So the Arrival trial, and these are kids where they measured fecal elastase before and after initiation of ivacaftor between 12 and 24 months of age. So really, really little kids. And these are they checked the fecal elastase a whole bunch of times. And what you can see is some of the kids just were really low and just stayed low. Most of the kids went up pretty substantially. That dotted line in the middle is when you're considered pancreatic sufficient. And there are just a few kids who went up and then went back down. And then they had two other similar trials, the Climb and the Kiwi, which were in slightly older kids. And what you can see in the older kids, because that red dotted line is that same 200, the older kids started lower and not as many of them came up, but there were still a substantial number of kids that came up. And then this is a case report, but now we have lots and lots and lots of cases of people who are pregnant and on ETI and that have a kid who has 2 CFTR causing mutations, who has a normal newborn screen and a completely normal pancreas at birth. So that's happened a bunch of times now. So we know if you're on highly effective modulator therapy in utero, that you will have a normal pancreas at birth, which is not true for anybody else with a classic type of cystic fibrosis, whether a gating mutation or any other typical CFTR, like what we call a CF causing mutation.
Yeah, we have another question in person. Go for it, Julie.
Yeah, has anybody ever given a heterozygote mother who is known to be carrying a CF kid ETI?
Yes, they have. So the last NACFC, North American CF conference, there was a pediatric pulmonologist who advises people who are interested, and he has collected a case series now, and I forget the exact number, but it's pretty substantial for such an expensive medication, of moms who basically are known to be carriers and their spouse is known to be a carrier, so then they test the baby and then they go on ETI. And yeah, those babies are born with a normal pancreas, and if they're a boy, they're typically born with 2 normal vas deferens.
Wow, that's
yeah, it's wild. So
what do you do once the baby is born? Because Trikafta is only approved at 2 years, right?
yeah, it's a big problem actually. So I have you guys are like preempting my slides, although I don't have to be specific on this, but so let's see here. Let's hop through the fair. Yeah, so we're almost done anyway. So What happens in ferrets, CF ferrets, is if you treat them in utero, then they're born with normal pancreases and normal pancreas function. And if you leave them on treatment, they don't get, assuming they have 2 responsive alleles, they don't get pancreas disease and they don't get diabetes. If they only have 1 responsive allele, actually they may still get diabetes later, interestingly, in the ferret model. But what happens is if you ever stop the highly effective modulator ferret in the therapy in the ferrets, they get rapid, severe pancreatitis and rapidly progressive pancreatic insufficiency followed by diabetes. So we're actually pretty terrified about what's going to happen with these kids when they stop therapy in these situations. So what we typically do is, fortunately, ETI goes to breast milk. So the goal is to have the mom breastfeed until the kid is 2. If the mom can't do it, we put them immediately on some Deco until that they can go on to ivacaftor. That's what we do. Great question. Great question. And as far as I know, I don't know of any situations where that kid was completely without corrector therapy, mostly because if you have a family where the mom's getting ETI when she's a carrier during pregnancy, that's not a low resource family, right? And we know that kids got responsive mutations because those are almost always delta F508 families. So, but in those very, very ideal situations, they have managed to manage that. Yeah, that's a great question. So we have a tiny bit of data with adults. And as you mentioned, there's definitely documentation of people being able to go down on enzymes. As far as I know, and that's not this study, and I couldn't find any good published data, but as far as I know from talking to people who have like preliminary data and things like that, as far as I know, the ability to decrease enzyme therapy doesn't necessarily tightly correlate with measures of fecal elastase, because there are people who have been able to go off enzymes and do well, who still had, if you do a fecal fat measurement, still have a fair amount of fecal fat that they're losing. And the PROMISE data, as best I know, we're not seeing any recovery of fecal elastase in adults. So we are seeing people with decreased enzyme needs, but not really true pancreatic exocrine function recovery. And the thing is, I think is what's happening is that we treat pancreatic insufficiency and pancreatic sufficiency like an either or, but it's absolutely just a continuum. As you saw that those little kids where they're measuring their elastase values, there's huge differences. Different people with the same mutations are having very different amounts of elastase production. And so what it is a continuum. And so a lot of people who are pancreatic insufficient and historically would have needed enzymes still have some exocrine pancreas tissue and can make some enzymes. But of course, they're having those parts of the body are very, very sick without CFTR function. But if you can make the person really, really healthy, it's not really they've grown back or healed any tissue, but the tissue that you have is functional. So we're not seeing a huge amount of improvement in fecal elastase in adults for these treatments, but we certainly do see some improvement in kids. So, and I talked about this because you guys got me to it. So this is it. I'm at the end of my slides now. So what do I think? Highly effective corrector therapy is beneficial to both the endocrine and exocrine pancreas. It doesn't cure established CFRD, which you guys know. It's not going to cure pancreatic insufficiency in adults with CF. Although I think people improve in their need for treatment. It may improve insulin production, glucose levels, and reduce need for insulin, even in people with long established CFRD, even though it's not a cure. I think it's going to prevent progression. It probably really truly improves A1C in people with CF. I don't know what that means. We've never really truly known what to do with A1C in people with CF. And we're seeing improvements in A1C when none of the other markers of CFRD are improving. So I do not know what that means. But I know it's probably good. but I don't know for sure what to do with it yet. And probably to truly fix all this stuff, these medications need to start young before the pancreas is destroyed. Because I think a lot like what we see with the lungs, if something is truly damaged and scarred down, it's not regenerating with these medications, but anything that's still there can become healthy again. And the problem with the pancreas is the pancreas gets destroyed a lot younger than the lung tissue does. And I think that's what we're seeing more than anything else. And I think a lot of stuff with the endocrine pancreas is it's really dependent on the exocrine pancreas. So my guess is that lesson 2 is going to be good enough. We should be seeing with the big N populations and the little kids now, if that's actually true. But definitely if we can do it in utero, we know it works. The trick is what that exactly means and if we cause other trouble later. So I edited my natural history slides with what I think might happen. So I think we can treat everything if we start in utero. And I think people won't have any pancreatic insufficiency if they're treated in utero and going forward. I think of people who can get and do respond to highly effective modulator therapy and are able to stay on it, will not have any pancreatic insufficiency, and I don't think they'll have any diabetes. And I think in people, even if they start highly effective therapy later, I think we're going to see a lot less progression of abnormalities and just people staying where they are, but not getting worse the way we used to. And I also think that CFRD is going to be a lot more like other kinds of diabetes in that the primary problems with diabetes are going to be diabetes complications and not lung complications in people who are able to get access to and stay on and respond to highly effective modulator therapy.